Hi, good afternoon. My name is Mark Tyson. I'm a urologist here, and I was asked to give a talk on how do we convince people to do this. You've heard a lot of good data today about why we should do it, but implementing it and convincing your colleagues it's a good idea is a completely different story sometimes. It can be more of a challenge than you realize. And I would like to start by saying what an incredible turnout for this course. Dr. Young-Fadok is a really nice course, and to be speaking with powerhouses to follow you, for example, is crazy to me. So thank you for having me. I'm sorry to disappoint you in advance. I don't have any relevant disclosures. I edit the Journal of Urology. I'm a paid consultant for a couple companies as well. Most of my practice is bladder cancer, where we're trying to implement ERAS. Part of the challenge with urologists in general is that we often like to think of ourselves as pioneers. We say, well, we've been doing ERAS for a long time. Here's an example. A paper by one of my senior mentors from 1991, right? This is actually a paper from 96, but he had published a very similar concept in 1991 for radical prostatectomies. And I do think urologists deserve some credit for collaborative pathways, enhanced pathways, those kinds of things. But really, ERAS is more than that. And that's where the challenge is. It's more than about some of these common misconceptions. It's not just a post-operative protocol that's standardized. And this is where you really have to engage the folks that you're working with and meet them at their level, where they're sort of raising these issues for you. I'll give you an example. Urologists will often say, well, hey, we have a low length of stay. Radical prostatectomies have been going home same day for a long time. Here's an example published out of this institution where we started sending prostatectomy patients home the same day. And it's a huge leap for robotic prostatectomy patients, or prostatectomy patients in general. And partial nephrectomies are going home the next day, for example, especially if you do them robotic. Cystectomies were, I had a guy go home 2 days recently. But ERAS is more than about length of stay. And you have to really start to say, well, what is ERAS really about? And in order to answer the urologist who says, well, I'm already kicking butt, right? This is what they'll say to you. I'm already doing great. This is what my colleagues say to me. And so you have to say, well, what are the primary barriers to implementation cognitively from your colleagues? And so I'd like to just challenge two of them that we see frequently here, just among our colleagues, who are all experienced laparoscopists and collaborative care pathway adopters, early adopters of a lot of these principles. But ERAS is different. ERAS is not just about length of stay. We have no need for ERAS because our length of stay is already low. In the case of the radical prostatectomy is often brought up, right?